Yvonne is Assistant Professor at the Australian Institute for Healthcare Innovation at Macquarie Uni. Welcome, Yvonne.
Thank you very much. So I'm going to try and unpick some of what Nick has set up for me very beautifully. And he is a hard act to follow, but I'll do my best. So I'm the Associate Professor of Health Systems Sustainability. Sustainability is an operative word here, so I will take a sustainability lens while looking at integrated care. Here we go. So I'm going to tell you a little bit about where I'm from. We're going to talk about health system sustainability and integrated care and why we're really interested in those two concepts. I'm going to talk quite a bit about implementation and evaluation of programs. And just to mark my spot, I actually think you cannot implement without evaluating. Those two things go hand in hand. It's not one and then the other. I think it needs to happen as an integrated system. Then I'll go through some real life examples, and I'll go through some of the lessons that really resonate with me personally, and they may resonate with you or not. And you may want to speak with me about that later. I'm very happy to have a discussion. So at the Australian Institute of Health Innovation, our mission is to enhance local, institutional and international health system decision-making through evidence and use system science and translational approaches to provide innovative evidence-based solutions to specified healthcare delivery problems. We have 180 researchers in the Institute, and you can see some of them there. We're running about 70 projects around the same time. We have a number of centres within the Institute. There are 3 centres that are sort of core to the Institute that you can see there, but we also have a couple of centres that are funded by the NHMRC, and the one that I am obviously most aligned with is the NHMRC Partnership Centre in Health System Sustainability. So a little bit about that. We have basically 3 streams, and we want to improve the system through analytics, technology and shared data, reducing waste and low-value care, and getting better value for the health dollar. And we've talked about all of these things in this conference. The Partnership Centre includes academic leads as well as leads within the system. So we are walking hand in hand with people from the system. And you can see, and you can see that we span across 5 states, 7 universities, and lots of organisations involved in the Partnership Centre. Here's some more of them, and I don't expect you to read that, but it's an endeavour that requires lots of collaboration and lots of work together in an integrated way. So what is sustainability and why are we worried about it? So it implies that the health system endures and adapts by ensuring limited resources, and they are increasingly limited, and that's physical, financial and human resources are used efficiently and responsibly enough to continually maintain or improve population and individual health and well-being in a constantly changing external environment. The health system is not static. It changes all the time. What happens on the ground at the front lines of care, what happens between patients and doctors and nurses and allied health professionals is very changeable, and it changes from day to day due to many, many different factors. So we are working in complexity. The reason that we're worried, and we're not the only country that's worried. This is a projection from 2010 from the Australian government, which projected that we would be spending about 7.2% of gross national product on health. So that was projected for 2049 to 50. In 2015 to 16, we were spending 10.3%. This cannot keep increasing. So why is this? Some of the reasons are, actually, there's a lot of waste. About 30% of what we do in healthcare has no discernible benefit for the system, for the patient. So we should really be looking at reducing low-value care. 10% of what we do is harm, and only 60% of what we do in the health system is actually evidence-based care. Meanwhile, there are external pressures impinging on the system. So there's a rise in chronic conditions. Climate change is coming. You would have heard about the fires in New South Wales. No doubt that will have effects on people's health. There's policy fragmentation and payer fragmentation. There are costs and limited resources, and rightly so, increasing consumer demand for high-value care. At the same time, we're throwing into the system breakthrough discoveries, frontier technologies, genomics, personalised and precision medicine, cost-effective models of care, new diagnostics, innovative therapeutics, biomed technologies, big data analytics. That all costs money. We need to be wise about what we actually adopt into the system. And we're not necessarily doing that particularly well. So we're worried about low-value care to the point that we're holding a session tomorrow in Sydney with about 120 people from all walks of life looking at treatment overload. Too much medicine that makes no difference, and we're looking for solutions. So hoping to get some really great ideas from that. And of course, there's a conference in December run by an international group on overdiagnosis. Okay, so if we go back to the Institute of Medicine, the 6 domains of healthcare quality, safety, effectiveness, patient-centeredness, timeliness and access, efficiency, equity. Many of these things can be addressed by models of integrated care. And we're not the only ones who are thinking this way. The OECD, the WHO, the King's Fund, the Commonwealth Fund, even the Australian Productivity Commission has called for more integration in healthcare because there is enough evidence to show that it does improve care quality, it improves patient outcomes, it reduces complications, and it improves efficiency for patients, providers, and the system. So integrated care models abound, and as you can see, the OECD includes integrated care in the middle of its model. There's another model from New South Wales, from the Agency for Clinical Innovation, and there are lots of models for integrated care. This model, which Nick alluded to, but this one's presented in a lot more simplified form, and it looks simple. You diagnose, you analyse and design, you implement, and then you evaluate. It doesn't work that way. Firstly, you need to evaluate your problem. You need to really go deeply to diagnose what the issue is, but not only what the problem is, what's going right. We do 60% of the care provided, we're doing that right. So why is it that in some places this is done really well and in some places not? So understanding those things and unpicking it is really quite important. But of course, integrated care models and initiatives lead to lots of activity, and we have strategies and approaches and tools and co-design frameworks. They're abundant, they're everywhere. There are new models of care, implementation trials. And I'll stop there because everyone thinks of a trial as a randomised controlled trial, and Nick alluded to this. In this space, RCTs don't necessarily work because they cannot take account for all the variability and complexity of the system and of the integrated care interventions, for the want of a better word, that we are trying to implement. And so we're also wanting to build capacity, and of course we do need to do robust and appropriate evaluations for whatever we do. But we don't do that particularly well. And then overlaid over all of that is more complexity. So the health system, it can be seen as a social system, as a technical system, as an economic system. There are things that impinge upon it and influence it. The economy, consumers and patients. There are political influences. There's workforce. The media has a role to play. There are providers. The changing demographics, that all has an effect on what we do and what we try to do. So understanding systems into which we implement is crucial to effecting enduring change. Our health system is complex, and thank you, Alison Verhoeven, for developing this lovely diagram. I had no idea it was you. But this shows the Australian health system. So the inner ring are the three main sectors in the health system. The middle ring shows the relative size of expenditure and who is responsible for the delivery of services in a particular sector. And the outer ring is the relative size of funding and funding source. And you'll see that not much aligns in this model. There are fractures and misalignments all over the place. That can be good and it can be bad. And often it's challenging when you're trying to integrate, particularly across sectors. So understanding what happens on the ground is really quite important. This is an example from some of the work done at my institute. This is Janet Long's work. She looked at Lynch syndrome and she asked oncologists, what happens to people? How do you manage these people? Lynch syndrome is a precursor to cancer. And so, if someone's tested and they have, and they're deemed to be at high risk, they need to be referred. So of course they talked to oncologists. Oncologists said, okay, we screen them. If they're at high risk, we refer them. Simple, right? Simple, linear, no worries. Worries. So this is, Janet and her team looked at how oncologists actually did this. And it's way more complicated than that. And everyone thought that not many people would miss referral. They did. People thought that that patients would be willing to go to private clinics. They weren't. So there's a big difference as to what we believe is done, work as imagined, to the work that is actually done, work as done. I don't expect you to read this, but this is another example of the complex interactions in one emergency department during one shift. Okay? This is what happens in our health system every day. And we need different ways of looking at this and understanding this. And doing an RCT will not tell you any of this. You need to do observational studies. You need to understand the workflows and understand how people work together, how they work with their patients, how they're interrupted in the tasks that they're doing. And they are interrupted all the time, particularly in ED and in ICU, in those high pressure areas. Models are very, very good and helpful, and I have a pet model, and it's this one. It's called the Consolidated Framework for Implementation Research. And it's consolidated because it includes many, many different models, many aspects of different models. And as you can see, the main sort of domains are characteristics of the intervention, the inner settings, what's happening inside the system, outer settings, what's coming in to threaten or to facilitate, the individuals, what are the individuals like and what do they do, and also the implementation processes. Now, when I go to conferences and I listen to talks about integrated care models and implementation, most of it centres around characteristics of the intervention. We need to do a bit more than that, because the characteristics of the intervention are not going to help us to effect enduring change. We actually need to understand all of these things. And we particularly need to understand the implementation processes. Here's another model. I won't go through it because I'm running out of time, but I recommend that you read this paper, When Complexity Science Meets Implementation Science. Many people have come up to Geoffrey Braithwaite and said, this paper changed my life. It's really worth reading because it encapsulates what needs to happen for systems change. So what does the literature tell us? Well, in terms of sustainability, we looked at 91 papers, and Sturman et al. Looked at 125 papers. Many papers report sustainability at 12 months. And that's just the maturity of those programs. But the longer term assessments and evaluations are not there yet. I think we're a young science and we're a young movement. So, where it says over 24 months, it really isn't very much over 24 months. So most programs report up 2 to 3 years, 4 years. Use of theoretical frameworks is also quite poor. People don't use it. And the operational definition of sustainability is also not used very much. And when it is used, it's highly variable and people make up their own definitions of sustainability. So implementation is a complex activity that occurs in context. It requires relationships and engagement and champions and leaders and opponents. And opponents, don't forget the opponents, because you're going to have to engage with them in order to effect change. It requires networking and communication, negotiations. Models need to be adapted. Readiness for change needs to be assessed. We need capacity in workforce and in funding. We need good local governance that recognises the importance of integrated care. And we need sensible payment arrangements that support integrated care. And of course, on top of that, there is culture and policy. So this is an example of some context mapping for high-performing hospitals. And this is the sort of work that we really need when we're developing interventions or integrated care models. We need to understand what is happening at the moment in order to be able to respond appropriately to a particular issue that's happening in context locally. This is another example and you can look at it. But I really want to focus on evaluation in the few minutes that I've got left. And it's so important because we need to know the successes and failures and the reasons for those. We need to know the core components: fidelity, adaptability, feasibility for scaling and spreading, so that we can make wise decisions about investing, adapting, and ongoing evaluation. So we do summative evaluation quite well. We tend to look at, the degree of success, effectiveness, goal achievement. We look at impacts, outputs, products, and outcomes. What we don't do is we don't tend to design those things from the beginning. And that's where often our evaluations fall over and good ideas are lost. So it's really important to design and embed from the very beginning. This is a schema that we developed for an evaluation project at the Institute. But really what I want to draw your attention to is that co-design of the evaluation, not just co-design of the model, but co-design of the evaluation is really important. You need to bring people along with you. And of course, nothing is linear. There are cycles. Formative evaluation, which I've alluded to before, is crucial. You really need to do a deep formative evaluation pre-implementation to assess what is happening and use that knowledge for your implementation and for the co-design of your models. But formative evaluation doesn't stop there. You need cycles, feedback during the implementation phase. There are very few models that are perfectly designed first go. And you don't want to throw out the baby with the bathwater. You want to be looking at the model and how it's progressing and actually adapt it to the local situation and maximise its impact. Then the other thing that we're not doing terribly well is the interpretive evaluation. Post-implementation, retrospective evaluation of implementation. That's a lot of words. But essentially, we want to know what worked, how did it work, and why did it work, and for whom did it work. So if we're going to be scaling and spreading interventions or models, we need to understand this, and we need to understand this in detail. You won't do this through an RCT. You need other approaches, mixed methods approaches, quantitative and qualitative synthesis. You might want to do some network analysis. Social network analysis is fantastic. This is an example looking at the collaborations of a translation cancer research network over time. And that's what you want to be seeing in your model, is that you're growing networks, you're increasing connections. Okay, and we come to an example, and I've got 3 minutes left. So this, I'm sure many of you have heard about this, this model of care coordination for children with medical complexity at the SCHN in Sydney. I'll skip through that. But basically it was a care coordination model that used routine data to identify kids. It assigned a care coordinator. It identified all team members. It tried to move care closer to home. It tried to link the family with the local hospital so that families didn't have to travel, you know, lots of long distances to access the metropolitan children's hospitals. It optimised management in between visits. It used telehealth consultations. It used an app to help the families actually manage the healthcare. And it had shared care plans as central to the model. There was a 24-hour hotline as well. So one of the things that this model did really well, and this group did very well, is they did a very deep formative evaluation with families, with providers, and with policymakers and decision makers. You can read about this. I'm 2 minutes, oh my God, okay. We had a summative evaluation logic model, so obviously we wanted to know the impact on patients, providers, and the system. And there were significant impacts. And I think the key to success for this model was that there was that extensive evaluation, that there were champions and sponsors, there was engagement. The model was truly co-designed with families and with providers. There were feedback loops, and there was rigorous summative evaluation. And also it was aligned with state policy, so that's important. The other one is Lifespan Suicide Prevention Program, which is a work in progress at the moment. So we're engaging with the Black Dog Institute to do a post-implementation evaluation of the process. It's a complex intervention. There are 9 different strategies for preventing suicide. It builds collaborative networks. It works with community groups. It aimed to work with frontline responders. It went into schools. And it was implemented in 4 very different regions of New South Wales. So Newcastle, the Central Coast, Illawarra Shoalhaven, and the Murrumbidgee, which is an enormous area, enormous rural area. So we used focus groups, interviews, data that was available, document analysis, social network analysis, etc., and consultation with the Black Dog Institute. And surprise, surprise, one size did not fit all. The strategies were implemented variably. The collaborative networks were highly valued, so that was one of the things that really resonated across all of the sites. Pre-implementation formative evaluation was a bit sketchy. Planning was a little bit sketchy. Resourcefulness, creativity and resilience of those implementing was fantastic. But they were, if you look at this, this graphic here, they were driving a car while laying the road. And this is how they expressed their journey while implementing this program. This could have been done differently. So governance structures had a huge impact. So whether the program was implemented via a local health district or a PHN or an NGO, it had enormous impact on how the implementation went, and the facilitators and barriers that were that the implementers came up against. So there were lots of local factors that could have been better optimised and leveraged through through formative evaluation. So I won't go through my learnings because I'm out of time, and you can talk to me about those. But I'll leave you with this, which is a quote from Tricia Greenhalgh. Decisions must be made on the basis of incomplete or contested data. That is normal in the health system. People use their creativity and generate adaptive solutions that make sense locally. The articulations, workarounds and muddling through that keep the show on the road are not footnotes to the story, but it's a central plot. So that's the final word from Tricia Greenhalgh. This is the final word from me. To implement at scale, we need to bring implementation and evaluation together in context. And I'd just like to acknowledge the wonderful teams that I work with, large teams. And it's been fantastic working with everyone. Thank you.